Come on. Idiots. Mac person? Any Mac people here? I got to switch screens. There's got to be a side person. Nobody? I need to switch screens. Yeah, I don't want to see. This is the screen I want. There must be a second screen that came up because something happened. It's up here. There's like a choice 1, choice 2, but I don't know what it is.
Probably something related to mirroring too.
It's not mirroring, I don't think.
Yeah.
There's a second screen that came up because this thing stopped working.
Oh.
I know it's right between pages. I know that. But basically, there's a second screen showing. Yeah. That's the problem.
So you do want a mirror?
Yeah, we can just mirror. Yeah, arrangement. Thank you.
Right. Some screen.
Is Minot here today?
I don't think she's on Wednesday.
But Devin, she here? What? I can do whatever I want.
That's the funny thing about it.
That's funny. Yeah, we had a lab vote yesterday, and I vetoed the vote. I felt like.
But you sort of vetoed it, but then you didn't. And you vetoed.
Decided. Okay. Last class. Let me try my Italian, which is pathetic. 24? Is that right? Anybody? No? It was okay? All right. Thank you. I'm ready to go to a meeting in Venice. Yeah. So today we're going to talk about visual agnosias, these visual perceptual disorders, which are really fascinating, give you one more insight into how the brain is organized for behavior. So if somebody could you do this for me, sir? Look, tell me what you see there. What do you see? Yeah, what do you see? A what? Green marker, and is it moving? It's moving, and it's in a spatial position, right? You don't see spatial position. You don't see green separately. You don't see movement separately. You don't see the object shape separately. But there's 4 separate streams in your visual system extracting that information. And then they get glued back together within about 200 milliseconds, and you see this seamless percept. And what you see in visual agnosias is damage to these different processing streams that allow you to know up here is a green marker moving in space up to your left visual field. So how does that break down in disease? We've been through this before. We know the primary visual system is the geniculocalcrine pathway from the eyes. And we know if we knock this out, you get various amounts of visual dysfunction, either a quarter of your field or all your field. But you can still recognize objects if they get into your good field. You don't have any problem with extracting color. You don't have any problem extracting object shape. You don't have any problem extracting motion, and so on. There's a second important visual system that leaves V1. Now, I want to just say there is some evidence that there's a lot of feedback activity, but for purposes of neuropsychology, this will do. V1 breaks into two pathways, the where pathway and the what pathway. The where pathway is basically, this thing is up in your left visual field. It's your spatial location. The what pathway is, what are you looking at? What's its color? What's its shape? And in fact, what is it? So these, you can get dysfunction in this pathway and get very selective deficits, which I'll show you. You can get dysfunction in this pathway and not be able to spatially localize information. And in the worst case, you can get damage in both, usually from a stroke, but sometimes from Alzheimer's, and even sometimes from a post-cardiac arrest, where the whole thing breaks down and you have a really hard time doing anything in terms of visual perception. So there's extensive crosstalk, as I mentioned. And again, if you see the baseball hit by the right-handed batter into left field, this pathway saying, that's a baseball. And this pathway, this parietal pathway, ventral stream pathway for what? Parietal stream pathway, it's heading into left field. You do it fluidly. You don't even think about it. Brains are beautifully organized. Lots of monkey data on this, and this is what we're going to go into in humans. Where's the breakdown in this system? And we've learned from monkey data in some of the that there's a color area that actually ascribes color to objects, not the object, but the color of the object. And I should say a lot of this seminal work was done in the Berkeley Psychology Department by Russ Develoy, maybe 20, 30 years ago. Really brilliant stuff recording in monkeys. And then we know there's a spatial system in monkeys in your inferior parietal cortex. There's a motion area in monkeys that is activated if the animal sees something move in their environment. So there's a lot of basic physiology in animals on these pathways. Very interesting, but that's not the essence of this course. That could be a completely separate course on systems and computational neuroscience, which would be in its own right an interesting course. So what we're going to talk about is humans, not monkeys. It's pretty simple, the organization. Here's V1. V2, that's where your visual information from your eyeball ends up. And then you go into this more dorsal pathway, into the parietal lobe, and this more ventral pathway. And one of the first waylay stations is V4, which is your color area. And then you go anterior to that in the ventral stream, and you have things that can actually identify what object it is. Is it a sphere? Is it a rectangle? Is it a face? Is it which face, etc.? Okay. So, and then you have another area. So this is the medial view of the brain. Here's our beloved corpus callosum that we talked about in the seminal work by Michael Gazzaniga in patients who had splits of the callosum for intractable epilepsy. So this is medial hemisphere. Then lateral, you can see another area here called V5. So V4, and then V4 is about here, and then V5 is a motion area. That's activated when something in your environment moves. So right now, if I don't move, your motion area is not activated. If I move, it's activated. It's pretty much as simple as that. Now, the first syndrome, which is very uncommon, but as we've discussed in this class, if you got it, it's pretty common. It's 100%. And, I've seen not several, but a handful of cases over the year where you get a very selective lesion in V4. This is a small infarction. It's probably that big. It's maybe 2 centimeters at most. And you knock out your V4 area, and if you showed the patient a flower, and you had him fixate right here, you'd say, well, what do you see? And if the lesion was in the left V4, the left ventral area, the patient would say, well, on the left side of the flower, I see the green stem and the yellow flower and the petals and et cetera, red. But on the right side, you know what, Doc? Everything's just black and white, or gray. There's no color at all. This is a syndrome called hemi, which is one field, achromatopsia. Big chewy word, it means loss of color vision. Now, there's a lot of genetic causes of color vision, but that's not this syndrome. This is actually not something related to retinal physiology, but it's something higher up in the processing pathway in the cortex where there's a selective V4 color area. So this is in the real world. Here's actually one of our cases, actually one of my cases right there. There's calcarine cortex. This is, by the way, you can tell this is a pretty old scan because it's pretty grainy. The pixel resolution in new scanners is remarkably better, but, you go with what you got, right? In 30 years, they'll be looking back at what we're doing now, and the young clinicians will be saying, what were they doing? How could they do anything with those lousy T1 and T2 and et cetera MRI scans? We've got blank. In any event, there's a lesion right there, and it would be sitting right there. And here's what the patient reports. If they looked right here, they would say this cable car, they saw every color vividly. On the right side, everything is in black and white. The detail is still there. They haven't lost the details of the object. There's very high resolution. You can see, they see beautifully all the different petals of the leaves on the tree, but they have hemiachromatopsia. Now let's go up the processing stream to the next area. And this is there's a face area in your brain. Now I'm not going to go into the big arguments about whether it's only faces or does it respond to other objects. I will just tell you this. There's a famous neurological case where the person developed the syndrome I'm going to describe, prosopagnosia. Inability to recognize faces. So if they looked at you and you were a family member, they wouldn't know who you are. Now say something to me. I would know who you are based on your voice. So I would have a visual, perceptual deficit in decoding what your face is. Now, we'll go into this. You'll see it. It's quite remarkable. But I will just say there's a famous case of a farmer who got prosopagnosia, who couldn't recognize any of his family members' faces. He'd actually labeled. He'd given names to all his cows. He could no longer tell which cow was which name. So he actually had face agnosia for cows. So I'll let the experts sort this all out. But let's just stay with the fact that it's predominantly for faces. Then one higher up in the processing stream, we have area V5. It's a doctor in Germany. I got to talk to him. Heil? Heil? Can I call you back? I'm in the middle of a class. Yeah? Okay. No. The class will be over, and it's over at 11. I'll call you as soon as I'm out. Okay? Okay, bye. Sorry. I can't go into what's going on, but I had to take the call. Okay, so this is your motion area of the brain. And if you have a lesion there, now it's rarely studied in one field, because if you have motion detection, if one hemisphere is intact, that's enough for you to detect in general by moving your head around where things are moving in the entire visual field. Typically, people with motion deficits, echinotopsia, have bilateral lesions. This is, again, one of our cases that we published several years ago. Again, a very, very grainy, I think it's from 1991, but there's bilateral lesions in area V5. And if you this patient's perception of the world is perfect. They see colors. They perfectly see shapes with fine detail. But if you show them something moving, they don't see the movement. So if you show them a video of water flowing into a glass, they perfectly see the spout, the water, the glass, but they don't see the water flowing. They can't detect motion. Rare, but really very powerfully insightful into how things are done. Now, if we go into do our PET scan, glucose uptake PET scan, basically, that's going to decay and produce two alternating annihilation photons, and I show a very simple movie to the patient. This is a really old study. This is some of the early stuff using PET scan. Now, PET scan is not really used because of the problems with potential radiation. See what's happening? The movement area is activated, and the color area is activated. This is really old. This is from the 80s. So people have been trying to, right? There's V4 to the color moving, and here's the motion area in V5. So we could actually pick these out. Now there's all kinds of fancier methods to do it in fMRI, which we've talked about extensively. This is one of the very first attempts to show that you have these parallel pathways. They're activated at the same time. They're doing something completely different. Now, let's go back to prosopagnosia, because this is the inability for your family members to know, your family members to know who you are. Yeah?
So with actinopsia,
Yeah.
will those areas not activate?
Yes, they would not activate because they'd be lesioned. With actinopsia, actually you see a patient with this, they'd have lesions in both areas. So there's nothing for the glucose to be taken up into. That thing I showed you was you in the scanner, looking at color and vision and showing your V4 for color and your lateral motion area for motion. Okay? Yeah? Okay. So let's go back to faces and places, because this is really a lot of work being done on this at Berkeley and many other places, but Berkeley's done some really elegant work. If you put someone in an fMRI scanner and I show them a lot of faces, turns out just in front of your V4 color area, there's another area that's pretty selectively activated to you seeing faces. This is the fusiform gyrus right here. It's a gyrus on the inferior part of your temporal lobe that's selectively active to faces. There's actually another area just even a little more anterior to it, which is a place-selective area. So if I have you do charts through MAT and you kind of go through something like rat mazes and take yourself through a 2D or a 3D environment and have to try to figure out where you are, you'll have place-selective activity in the parahippocampal gyrus. So all these things are sitting there waiting for visual input so they can rapidly pull all these little aspects out and then send it back up to association cortex, glue it together, so you see a seamless percept. You get the same face response even if the face is inverted. Right? So this is Bill Clinton. This would get the fusiform face area. This would get the fusiform face area. Now, we do see patients with strokes in this area. They're typically strokes, and they're almost always bilateral, but sometimes you can get them with only right-sided strokes that infarct this area. And as I pointed out, these patients cannot detect and understand what a face is. But they know who the person is because when this young woman spoke, I could recognize her. Now, wait 1 second here. I just want to make sure I got yeah. So I was moving stuff around this morning. Okay, so prosopagnosia, bilateral fusiform lesions usually, can't recognize faces, can recognize when the person speaks. I already told you about the case of the farmer, which calls into question if it's an absolutely specific human face area. And I'll let that to the experts. Here's one of my cases with fusiform gyrus infarctions with very bad prosopagnosia. In fact, these are the kind of patients. There's a famous case that's been studied. No, that's a different case. Basically, these patients, let's say the patient met any family member, they'd be unable to distinguish them unless they talked, or perhaps if they wore some distinctive piece of clothing not related to their face. They might guess you're the family member because you're an undergraduate Cal, and you're the only undergraduate Cal who will be wearing a Cal shirt, maybe, who knows. So there might be other visual cues. So here's the patient here with an infarct here, and a patient with an infarct here, usually bilateral. And again, if you note, this is, of course, a coronal section. Remember your axial and your sagittal and your coronal sections. This is a coronal section with bilateral lesions. These are typically lesions in the distribution of the posterior cerebral artery. They're in the inferior part of the temporal lobe. And again, just for comparison, this slice is about through here, and you can see where a normal person, not the patient, but a normal person would show activation. Of course, if you put the person in a scanner with these lesions, there'd be no activation because there's no face area to activate, right? It's not possible for anything to happen. So here's a really interesting case from my colleague, Yosef Parvizi, at Stanford Medical Center. We do a lot of collaborative work in intracranial recording. Really has a superb lab, and he's given me one of his movies of a patient, not with prosapagnosia. This is a patient being monitored for epilepsy, and this is from his cohort of many patients. 2,000 electrodes, that's not what a typical patient has. They may have 80 or 90 or 100. This is where the fusiform face area is, and he said, you know what? Suppose I go in and disrupt it. I shut it off with electrical stimulation. What happens to a normal person? The person's normal except for the fact they have seizure disorder. Okay, so what happens? First, what he did, and you don't need to go crazy about figuring this all out, but what he did is he got both ECOG recording and localized where the face area was by looking what area in this is the inferior temporal lobe, what area was activated when you showed the patient faces. So he knew where that patient's face area was. He also did in the patient fMRI scanning and showed them faces, and again, had a really good idea where the face area is in this patient who has no face processing deficits at all. Okay? So here's the patient, and I think you'll see what this syndrome is like. And this is, of course, he does not have permanent prosapagnosia. He's had disruption producing it, transient disruption. Okay, what happened to the sound? This is the worst system on the planet Earth. Volume on. Select up.
Yeah, do that one.
1, 2, 3.
Wait. Thank you. I thought I had it after 24 weeks. I guess I didn't.
Okay.
Sorry.
Just look at my face and tell me what happens when I do this. All right?
Stimulate. He's disrupting the fusiform face area.
1, 2, 3. Nothing?
Sham.
Okay.
He had the sound of the
One more
stimulator,
time.
but he didn't stimulate. You need a
Look
control.
at my face. 1, 2, 3.
You just turned into somebody else.
Tell me
Your
about
face metamorphosed. Your nose got saggy, you went to the left. You almost looked like somebody I'd seen before, but somebody different. That was a trip.
it. Could you see my eyes in place?
I could see your eyes, but you could have been somebody else who had, well, he has similar eyes to Dr. Parvizi, but you were someone else. Your whole face just sort of metamorphosed.
Did it get warped?
Yes.
Did it keep its own features?
No, it's
Or
almost
shape?
like the shape of your face, your features drooped. Yeah, sort of like they drooped to a particular direction, kind of stretched and drooped.
All right.
Okay.
Ready? 1, 2, 3.
Yeah, it metamorphosed again, and you look like someone I've seen before, but maybe a different person in my memory. Almost like your nose kind of shifted to the left a little bit, and your look just changed.
It did.
Yeah.
Tell me more.
Well, I mean, I don't have a photographic memory, but it just, you turned into someone else. You looked like someone else.
Did I keep my gender?
Yeah. Oh, yeah.
How did you know I'm not a female?
Because you're still wearing a suit and tie.
Oh, you could see the suit and tie.
Yeah. Only your face changed.
Don't.
Everything else was the same. Yeah.
Okay. I think you get the feel for this. It's kind of amazing,
yes.
right? And you can actually, it really gives you a perfect example of this highly selective function. If you'd gone in and went to area V4 and turned that off, you would have had a hemifield deficit in color vision. If you did it on the left side, everybody here would have color. Everybody here would be black and white, basically. And by the way, you could see how attentive and cooperative and intelligent the patient was. So, I don't want you leaving this class thinking epileptic patients got a problem. Okay, they do have a problem. It's a medical problem. They're epilepsy, but they can be completely normal people. So now let's go one step up the food chain, where we're not talking about a selective deficit, but a really profound disintegration in being able to perceive and understand the external world. And these are called agnosias. Failure in synthesizing visual information into an object. The patient sees the object but can't identify it. It's not anomia, as you will see. It's always bilateral parietal occipital lesions. They're not as well delineated in exactly where, but it's always bilateral. These cases are not that common, although I will say you can see this in most Alzheimer's is presenting in the temporal lobe with amnesia, but there are cases I've seen, and Bill Jagus, my colleague, has seen even more, who actually present with a posterior presentation with problems with visual agnosia. The patient, if the patient touches the object, they can identify it. That means they're not anomic. If I gave a patient a key and asked them what it was and they couldn't name it, looking at it, and I had them hold it, they still couldn't name it. They're having a deficit in finding the name of the object. This person cannot visually perceive what the object is unless they touch it. There's two subtypes. I'll show you both. This is the most common type. The patient can see the object well enough to draw it, but they can't identify it. They just can't extract enough information. And then there's a very severe form, which is called aperceptive. These are rare as hen's teeth. These patients really can't even tell an X from an O. They have a very, very profound disintegration of vision. I'll show you a couple movies of these patients. So this is someone with a less severe visual agnosia. If you show them the shape, they can basically trace it. And sometimes when they trace it, because they get manual input, they can tell exactly what it is. So they certainly see the object, right? It's not like the object's not there, right? So here's an example. See it, copy it, see it, copy it, see it, copy it, and so on. And here's what they look like. I'm going to show you just a couple short movies. And this is my friend and colleague Barbara Fell, who's really just an outstanding neurologist and behavioral neurologist, but a general neurologist also. He meets the criteria for a really good doctor. Do you know what the criteria is? Anybody have an idea what's the criteria for a really good doctor? If you ask a doctor, another doctor asks another doctor, should I send my mother to this person? If the person says yes, that means the person's a good doctor. That's the inside way of kind of determining exactly what the spectrum of doctors are. Would you have your mother take care of him? And I would have Bob take care of my mother. Okay, here we go. This is a pretty severe one.
Can you make out what this thing here is?
Teabag.
Well, I'm not sure what it is. I think it's something on a string.
He sees the string, actually, the detail, but he can't get the object.
Yeah, I see the string.
Can you reach out and touch it? Does it help you to touch it?
Teabag.
Right. That's that.
Bingo. Right? Now, an aphasic patient wouldn't do that. They still wouldn't know the name. So you're seeing this gentleman has a very severe problem with the visual decoding of the world, but he can bypass it with the tactile input. Pretty interesting. Let's try another one with this patient. They have a whole range of fascinating disturbances. And like a good neurologist, he misspelled
it.
it.
Square or a circle or a triangle. That's all I want you to do is tell me what the shape of it is.
Simple. Triangle. What is it?
And this one here?
Square, yeah.
No, it's not.
Hmm?
No, it isn't.
Another square.
This is a triangle.
He can't even decode a triangle from a circle from a square. That's how profound his problem is in decoding visual information and putting it into a whole. Okay? Bad visual agnosia. And there's many. These patients, when they're found, visual scientists study them like crazy because you can imagine all the different things you could find here. Where did I go? 1, 2, 3. Oh. Now, finally, Balance syndrome. Balance syndrome would be our last syndrome. But I thought I'd close with this because we really don't know what's going on. And it's not because I'm hoping that some people in this lecture hall someday will figure out exactly what's going on. Balance syndrome is really interesting. The patient cannot see two items at once. They see this, they say, whatever they call it, some kind of pen. They wouldn't know what this is, but let's say they knew. Here. No, you don't have any. Okay. Thank you. Pen, well, that's a different one. They see this, they'd see this. When you put them up together, they only see one. You take it apart. Let's say I see the blue thing. You take that away, they see the pen. You do this. You take away the pen, they see this. They cannot see two objects at the same time. Some people think it's a very severe constriction of it's like a double neglect. Most of the world is gone except a myopic little window of where you can see something. And you can really limit it to one thing in that little window. Really quite a fascinating syndrome. Failure to see two objects at once. Patient sees only the comb. If I take the comb away, they see the toothbrush. They think it's, whoops. Thank you. They have an abnormal shrinkage of their attention focus. That's what people think. They have optic ataxia, which I'll show you. They go to reach in space, and because they not only have problems in where objects are, because they have this more superior stream damage in spatial areas, they can't even reach for it. They almost look, they're not cerebellar, which would have an terminal intention tremor for fine control. They're just completely missing. They can't get the trajectory of where to put their arm to. Again, the lesions are always bilateral, and they're always, get out of here. They're always in the parietal occipital area, and you have damage in both pathways, and that's my little squiggle of a lesion. Here's one case that we presented and published extensive data on. You can see these extensive bilateral parietal occipital lesions from the back, right? Quite extensive lesions. And this patient had a Balance syndrome. And let me show you some of the symptoms. Again, best seen, I think, with a movie.
Okay, I'm going to move the spoon. Which way did it go? Toward you or away from you?
I can't tell.
No depth
Which way?
perception. Is it coming towards me?
I still
Is
can't
it going
Are
away
you
from
looking
me?
right at it? You can
Patient
see it,
can't
huh?
tell.
Can you see the spoon?
I can see the spoon.
Which way did it move? Toward you or away from you?
To me. Away from me. Away from me. Away. To me. I don't know.
I don't know. The patients are never absolutely one or the other, but you can see he has a problem. This is a very simple thing. Is the thing coming towards you or going away? They have misreaching in space. They have a whole spectrum of visual deficits, each one on its own worthy of extensive study. Hold on. Yes? No, they see the whole thing, but it doesn't matter if it's in front or behind. Whatever you show them, they only pick one. Their attention system gloms on to this one and can't move attention to this one. So if I take this away, they still see this, if I take this away, they see this. Not doing real well with this thing. All right. But it wouldn't matter if this was in front. You'd get the same effect. So it's not so much where it is, it's the object that's getting this misallocation of attention capture. So let's look at misreaching.
Reach out and grab it with that hand.
I can't do it.
Can you see
He
it?
doesn't have a terminal intention
see it,
tremor
I
like a
can't tell.
cerebellar
I can't
patient,
reach
right?
You seem to do better with your left
just
hand.
can't.
Take a crack at
Where's
it
space?
by holding it up closer.
Where are you?
All right, how about now that you've touched it with that hand, can you reach with the other hand and grab it? With your right hand?
With my right hand.
Uh-huh.
And his is worse in his right side than his left side. So that means he has more damage in his left parietal spatial areas. As you can see, if you start really looking at these patients, you can really glean a lot of incredible information on how your brain is wired to do all these things we do so effortlessly. So here's the same patient who also shows balance syndrome, simultagnosia.
Mm-hmm. No comb.
No,
How about now?
I can see the comb.
And the spoon?
I'm not sure about spoon.
Okay. How about now?
I can make out the comb and a spoon.
Good. You got them both.
Problems with two stimuli at once. And here's another gentleman with the same problem.
How about now?
The comb doesn't reappear.
Comb reappears. How about now? What do you see?
I see the comb and things, but I see the comb and everything, but it, just like I said, it reappeared again on me.
And what happened to the ruler?
I don't know, but see now I see the comb and things. What happened to the room? And I just want to say I do. I don't know, but I can ask somebody.
Can you imagine your attention flipping back between two shapes and you can't really stay fixated on one? These are really fascinating syndromes, which deserve huge amounts of study in terms of ballistic control, visual perception, the AI world, and they think they can solve all these problems with computational methods, and I'm a little dubious about it. They certainly can pick up aspects of visual perception, but what's actually going on, the real truth is what's going on in your brain. And the more we can understand about the brain, the more we're going to be very much better in our computational approaches to understanding normal vision. Yeah.
So what determines which object they perceive over the other when presented? Is there something that determines?
No clue. It's nice to end with no clue, because then hopefully you guys will be telling somebody about this. So what I said I was going to do, and I'm going to do, is show you 47 grandchildren pictures in movies. No, I'm not. I wouldn't do that. Some people might like it, but some won't. I'm going to spend the last few minutes just going over a few things related to the final. But before we do that, we don't have two of our GSIs here, but can you guys just stand up for a minute? Nick and Colin and Mano and Devin had classes. This course would not be possible without the work of the GSIs. As you all know in their sections, they just, they're building their careers, they're building their research careers, and they're still finding time to teach. So I really want to thank them very much for making this course as fluid as today. If we had the two other GSIs here, our team would have 5 people. What sport has 5 people on the court at one time? What? Yeah, I can't believe it. I made the national TV last night. Draymond Green hit a 3-pointer. I jumped up screaming, and I ended up on TV. I got emails from all over the place, movies. I'm famous, man. I am famous. What? It was the 3 minutes into the third quarter. People sent me clips. It was like crazy. I don't know how to get it off my phone. I mean, I would if I could. I'm too incompetent. If someone can take it off my phone, I don't know. I don't know. But I have to tell you, I have a friend who's a clinical neuropsychologist. This woman is really a very intelligent woman, maybe one of the best neuropsychologists I've seen. She calls me. I didn't know this, right? There was cameras all over. She calls me and she says, "Bob, are you at the game?" And I said, "Why?" She said, "Well, I just saw you on TV." I said, "Well, then I'm at the game. Why are you calling me to ask me?" I'm going, how could you be that smart and be that bing? All right. So, isn't the world strange? All right. So listen, the last few minutes, boom, boom. Well, this is better. Let's go over quickly what I think are some of the things you ought to be sure you know about in the class. History, right? You need to know the major figures. All the people we talked about who formed the infrastructure for this class, and remember, they did this without all kinds of fancy imaging stuff. They did it with their eyeballs and their intelligence and their observation of patients. And I don't need to go through the names. You know who they are. I want to add to that list Michael Gazzaniga, who's not from 1860. And if I told people that he was ancient, he'd be very upset with me. You should know methods, right? You should know what's the basis of a CT, what's the basis of an MRI scan, what's the basis of a PET scan. These are kind of elemental building blocks that you've seen that we've used throughout the course. You need to know, you don't need to be a neurologist, but I want you to have a gist for the neurological exam. What does the cerebellar exam tell you? What does the motor exam tell you? What does some of your simple cognitive tests for memory tell you? So go over that a little bit. I don't want you to be a neurologist, but I want you to understand that. Then dementia, you need to understand the basic pathophysiology. You know, amyloid and tau versus Alzheimer, tau and FTD, chronic traumatic encephalopathy, this upcoming scourge. Spend some time thinking about that. Epilepsy, again, we've talked about it a lot. I want you to know what a kid epilepsy is, like petit mal epilepsy, because you may run into it if you're a teacher or a family member. You never know. The difference between falling down and having a tonic-clonic generalized seizure versus stopping and staring and making some automatisms, and you have a complex partial seizure, probably coming from the temporal lobe. Those are kind of important core things you want to walk away with. Movement disorders, think about them as hypokinetic, Parkinson patients, slow and gluey, versus hyperkinetic, Huntington's chorea, with a lot of movements, and how they relate to either deficits or increases in dopamine activity. In terms of trauma, coup contra coup, I want you to understand that, because that's a big problem, and some of the people in here have already experienced coup contra coup injuries, and then I want you to understand what's the potential outcome from trauma. What areas of the brain are typically damaged? It's orbital, frontal, and anterior temporal, leading to social emotional problems. What about memory? No. First, tumor. What I want you to know about tumor is the difference between a tumor that's inside your brain, an intraparenchymal tumor, like a primary brain tumor, or a metastatic tumor that started in your colon or your lung, versus an extraparenchymal tumor. One's often deadly, one is not. An extraparenchymal will be something that grows between the skull and the brain, like a meningioma or acoustic neuroma. In the more neuropsychological, how is the brain organized? We talked about memory a lot. I want you to know that stimulus comes in, it goes into entorhinal cortex, magic happens in the hippocampus, gets sent back out to be stored. And what kind of diseases affect memory? And if you know what the anatomy of the memory system is, you can say that entorhinal cortex is where Alzheimer's starts. And maybe a cardiac arrest affects the hippocampus, and so on. That would be really nice if you understood that. We talked a lot about frontal lobe function. in terms of decision-making, executive control. Why did you take this course? What are you doing this summer? What are you doing in the future? These very high-level human things related to important things you do in your life. We talked a lot about emotion. Again, the key players, again, can be linked back to frontal temporal dementia and trauma, because those are the two big players that often get these areas of the brain. The orbital frontal cortex, the anterior temporal cortex, including the amygdala, and, of course, as added by Colin, the insula. Don't forget the insula, because I'm sure he's going to, the 4 short presentations by the GSIs, they're each going to have one question from their presentation, and if Colin doesn't ask one on the insula, I'd just be dumbfounded. I think. I don't know. You never really know. Neglect, fascinating, right? Fascinating disturbance. This failure in appreciation of the external world. But the understanding, though, that things that you don't see in your mind's eye can still implicitly affect your behavior. The fact that it's a right hemisphere syndrome. The fact that you can have this interesting problem with extinction, that you can see a stimulus alone, but not when it's presented simultaneously. Bing, I'm the patient. Left, left, right, 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 left, left. Extinction. Very interesting and important phenomenon. Aphasia, we've been over aphasia many times in the course. You know the key players. You know the general lateralization to the left. You know about Broca's area. You know about Wernicke's area. You know the things that you need to be alert to in the hospital or emergency room. Did someone make a weird word, a paraphasic error? It's easy to tell when someone's globally aphasic because they're hemiplegic and they can't do anything. Your job as a clinician is to pick it up early so that maybe you can intervene and do something before a more severe syndrome appears. Disconnection syndromes, there's 3 classics. I'd like you to know all 3 classics. Ideomotor apraxia, alexia without agraphia, and alien hand syndrome. Those are the 3 biggies. You saw visual agnosias, color, face, motion, high-level perception. We're not going to get deep into these things, but I'd like you to go away with some elementary knowledge of these particular areas. So, in conclusion, I just want to say I had a good time with this class. It's a good class. The questions have been excellent. The emails I've gotten have been excellent. The office hours have been very good with really people clearly understand the material. So I want to congratulate you on your efforts in this class, which I know has a fair amount of material. And then I will close with just a couple things because you're the future. And I'm hoping whatever field you go into, whether it's teaching or law or entrepreneur or business or clinical or I don't care what, you're going to grow pot up in Roseville. Who cares? Whatever you I don't care. Well, that would go under business, I guess. $85 billion projected business within 10 years. Think about that. It's more than all the packaged goods. It's like crazy. Hopefully, some of the things you learned in that class will be applicable to all these different fields of endeavors. And I know, hopefully it will influence, how you think about people. And then really finally, the key thing, you've seen how bad things happen to people, right? Bad things happen to people. You've seen bad things happen to people in your families or in your friends, etc. You really need to pay attention to one thing. And that's empathy. You need to have empathy for other human beings. If you don't, it's not good. And as a corollary to empathy, I really urge you to really pay attention to trying to control stigma. Stigma comes in all forms, for all kinds of things, from race to disability to sight. You pick your thing, and people, stigma's there, and you say, oh, that's easy. I'm smart. I can handle stigma. It'll never influence my behavior. Wrong. You've seen patients here whose behavior is influenced and they have no clue why it's being influenced, right? So there's implicit things driving you, and you just keep your guard up and just try to be a good person, and everything will go, really well in the future. So then finally, go Bears. Thank you.
Can I please see the video, a snippet of
Oh,
you?
yeah, sure.
Okay.
Yeah, yeah.
Stay Denise.
Yep, absolutely. Oh, great.
I realized that I didn't
Sure.
I was sort of like standing at the but it's not my transcript, so I'm just watching
Yeah, absolutely.
Where's the video? Let me see it. Can we just have a class email with it?
Post it on B courses.
Honestly, that should be part of the exam. Which hand did I wave more aggressively than the other?
Okay, here it goes. This is Draymond Green. He just got a 3-point shot. My friend sent this to me. Draymond, 3-point shot.
Oh my God! I'm a huge
National
Warriors fan.
TV.
I'm a huge
National
Warriors fan.
TV.
Please send this via
I'm
email.
gonna watch for this when I watch again.
Draymond just hit a 3. People are going crazy. And there's your course instructor.
You're amazing. That is awesome. That's good. Oh my God. Yeah. There's nothing I want to show more to my dad than that video. I'm gonna be like,
When I
that's
figure out how to
my
get it, I'm
teacher.
so confident. It's
Hilarious.
You're used to doing
Oh.
Oh. What's your name? I gotta write this down.
True. Too good.
Thank you, Professor.
Yeah, it's a funny thing when you're being mechanical, right? No one wants to make mistakes. I don't care who you are, and they're going like, a lot of them. They're not upset. It's like, I can't get it again. It's not really bad. The patients are not freaked out.
Okay, so it's not like, and like in terms of like a lot of these things, how does it affect their like mental health?
Well, that all depends on their family structure, right? And who's going to help them, right? If they're left, you have a severe visual nausea, and you're left by yourself, you got a problem. If you're severely have a Wernicke's aphasia, and you don't have family members who care, you got a problem. So the answer is in part due to what your social structure is.
So it kind of affects mental health in
Oh,
general.
absolutely. Oh, no. I mean, I don't think I mentioned it in the class, but maybe I did. Broca's aphasia often acutely are very depressed and crying, sad. You need to treat them. In fact, if they don't recover from the depression in a couple of weeks, maybe 4 weeks, I put them on an antidepressant. I mean, there's a lot of Wernicke's aphasia don't get depressed at all. They're like, they don't.
Because they don't
So it depends.
know that they don't fully
It's
understand.
hard to get in their head, right? That's the problem. That's why you need other approaches, all the modern techniques to try to sort out what's in their head.